Thanks so much, Tim, and welcome everyone. Thank you all for joining today's discussion. My name is Erica Phipps, and I have the pleasure of serving as the Executive Director of CPCHE, the Canadian Partnership for Children's Health and Environment, which is a national collaboration of organizations that have been working together since 2001 to increase awareness, mobilize knowledge, and catalyze action to ensure that all children in Canada have healthy environments in which to live, learn, play, and grow. I am also here in my role as co-lead of the PEHE Collaboration. Today's webinar is an opportunity to share the results of years of PEHE collaboration research as groundwork for the development of coordinated action towards the shared goal that environmental health education and advocacy will become a routine part of prenatal care in Canada. Today's webinar is the first in our Setting the Stage series. It's also the kickoff of our new PEHE-CCC project that brings together CPCHE and the PEHE Collaboration, two collaboratives that are starting the important work of filling identified gaps and strategizing how we can move this work collaboratively and effectively forward. I would like to recognize with gratitude the support for the PEHE-CCC project that is being provided by Health Canada and the Chemicals Management Program, plan via contribution to CANE, the Canadian Association of Nurses for the Environment, which is serving as the lead partner on behalf of CPCHE and the PEHE Collaboration. It's also my great pleasure to introduce Jack Avante-Struss, who is the past president of CANE and who is instrumental in this work and who will get us started in a good way with our land acknowledgement.
Hi, everyone. As Erica mentioned, I'm Jack. My pronouns are they, them, y'all, and I'm coming to you guys with my hat from the Canadian Association of Nurses for the Environment. I also want to acknowledge that I'm coming to you guys from Treaty 1 territory in Winnipeg, and I am so very grateful for living, working, and playing on the lands of the Anishinaabe, Cree, Dakota, Dene, Oji-Cree nations, and the homeland of the Métis Nations. And as a lead partner for this next collaboration that we're doing, it's really important that we go about it in a good way. So for all of us that have been working in this space for a long time, we know that certain people are disproportionately affected by environmental and climate injustices. And so as an organization, CANE is committed to righting the wrongs of colonialism by strengthening our knowledge and relationship with Indigenous peoples, where we live, work, and play, and by adopting decolonial and anti-racist practice and discourses. Therefore, as we go forward in this next initiative, we want to make sure that we are walking with and integrating Indigenous peoples from different areas in Canada as we move forward to putting these things in place.
Thanks so much, Jack. And we do have a couple of polls, which if you bear with me for a moment, I will see if I can launch them. Okay, it appears that that is not working at the moment. We do invite you, as Tim mentioned, to share with us the place where you're joining the meeting from, and also the sector or perspective with which you identify. So if you're working in clinical care, public health, social services, if you're an interested member of the community, please, we welcome you to share that in the chat. That was the gist of the participant polls that we had hoped to start out to get a sense of who's in the room today. So I will now attempt to advance my slides. Okay, so an overview of our webinar today. We will start with some of the reasons why prenatal environmental health is a priority for action, and then we'll share with you some of the highlights of the PEHE Collaboration's research. We will have an opportunity for questions and answers in the language of your choice, and then we'll move into our panel discussion with PEHE Collaboration partners. Today's webinar is a chance for us to reflect on what the research is telling us in terms of the gaps and opportunities, and to move from there towards action. Our discussions today are also an opportunity to start to explore, with input from all of you, what actions we must take and what strategies we could co-create to move forward on this important topic for the health and well-being of future generations. As we move through the webinar, please feel free to share your ideas in the chat. I'm having issues here. Okay, so environmental contaminants and hazards. Since World War II, toxic chemicals have been an increasing part of our daily lives. There are tens of thousands of chemicals on the market, with hundreds more introduced each year. Everyone is exposed everywhere we go in every aspect of our lives. Workplace exposures via products and food, and in our indoor and outdoor environments. Biomonitoring research confirms that we all carry burdens of many different chemicals: metals, plasticizers, flame retardants, pesticides, VOCs, etc. Exposures are often very low, at very low levels, but with uncertain and concerning consequences. Exposure to toxicants during the dynamic and highly susceptible periods of fetal and child development are associated with multiple chronic diseases, neurodevelopmental effects, effects on immune and endocrine function. Just as scientific knowledge grows about the links between toxic exposures and health, so too does public awareness and concern. A quick scan of any given news cycle or social media platform will reveal topics such as forever chemicals, microplastics, food additives, and climate-related extreme heat and wildfires. As scientific and public concern mounts about the effects of toxic chemicals on health and development, reproductive healthcare professionals have started to step up with leadership and guidance, including the 2015 statement of the International Federation of Gynecology and Obstetrics, the 2021 committee opinion from the American College of Obstetrics and Gynecology, and here in Canada, there remains a need for concerted action to address known and suspected health risks of environmental chemicals on reproductive, fetal, and child health. This point was clearly made in the co-authored commentary that helped to kickstart the PEHE collaboration research back in 2015, which fittingly entitled "Beyond Alcohol and Tobacco Smoke, Are We Doing Enough to Reduce Fetal Toxic Exposures?" And that commentary, co-authored by PEHE collaboration partners, recommended actions such as enhanced professional training, environmental health history taking with patients, and patient education as a routine part of reproductive and prenatal care. So the PEHE collaboration, the seeds for this multi-year collaboration were planted at a national forum hosted at the University of Ottawa in 2014, and the subsequent receipt of a multi-year CIHR grant under the leadership of the late Dr. Eric Crichton. The strength and magic of PEHE lies in the broad collaboration among health professional associations, researchers, government, public health, and nonprofit advocacy organizations. Through this body of research, which featured 2 national surveys and ongoing mixed methods research to contextualize our learnings, we sought to better understand current knowledge, attitudes, practices, and preferences from the perspective of both prospective parents and prenatal care providers. The first survey, a survey of women of reproductive age across Canada, was conducted in English and French via an online panel, and it saw the participation of nearly 2,000 respondents. Sampling weights were applied to ensure that the survey was statistically representative at a national level. Key findings were published last year. The link to that publication is in the chat if you're further exploring what we found beyond what I'm able to share today. The companion survey of prenatal care providers, doctors, nurses, midwives, public health professionals, and others, was conducted in the following year in 2022. Although the sample size, 474 respondents, is fairly modest, we attained a good distribution across disciplines and in terms of length of practice and percent of time spent providing prenatal care, as outlined in the summary table. So, what did we learn? There was strong agreement across the two surveys that the prenatal period is an important opportunity for prevention. Providers and women respondents alike agreed that day-to-day exposures can interfere with child development, and that pregnant persons can reduce risk by reducing exposures. Levels of agreement were roughly 9 out of 10 across the two surveys on these two questions. We explored with respondents what environmental health concerns were on their minds. Women respondents reported concerns about chemicals, pollution, and climate change, among many others. When asked what they felt should be routinely addressed as part of prenatal care, 9 out of 10 of the healthcare providers cited workplace exposures as the top issue, roughly 91%. Other topics that topped the list included sources of exposure in the home at 79%, contaminants in food, water and air quality, and climate change. Another key takeaway is that women and providers see value in action, but continue to face barriers. While most women, 91%, agreed that risks can be reduced during pregnancy by taking protective action, only about half said that they are doing so. 40% indicated a desire to take action, but were unable. The barriers that they cited included costs, limited awareness of safer options, and lack of time. A secondary analysis of the data from the women respondents who identified as racialized, indigenous, and/or living on low income suggest inequities in the ability to take protective measures despite similar levels of concern to the full data set. Most providers, 94%, similarly agreed that risks can be reduced during pregnancy, yet 50% reported never taking an environmental health history with their patient to explore routine exposures, workplace, home-based exposures, hobbies, etc. More than a third reported not providing information or resources to patients who had asked them questions about these topics. And when we asked respondents to what extent they take action to support a patient who's raising a concern, such as making a referral or writing a letter to support improvements in their workplace or home settings, 40% reported never having taken such an action. So one of the key aims of our research was to understand, are environmental health conversations happening during prenatal care? And if not, why not? Analysis of what respondents reported in the two surveys shed some light on this important question. For providers, most reported that their patients are not asking, they're not raising such topics with them. Providers cited barriers such as concern that in terms of sharing information with patients, providers cited various barriers such as concern that available protective measures would be out of reach for their patients. And their responses also point to important and actionable gaps in healthcare professional training and capacity on these issues. Nearly 60% reported a lack of knowledge, training, and guidelines as a barrier to engaging their patients in conversations about environmental health. I'll dig a little deeper into that in a few moments. A similar proportion, 58%, cited a lack of appropriate informational resources to share with their patients. Most had not received relevant training. And importantly, for our current efforts to fill gaps and mobilize systems-wide action towards routine prenatal environmental health education, more than 4 out of 5 of the providers wanted to see their professional associations become more active on these issues. So similarly, women reported not initiating conversations with their providers. Fewer than a quarter had ever discussed an environmental health concern with the healthcare professionals. Their responses also reflect a sense of reluctance to raise concerns with their provider, 20%. And the reasons they felt reluctant to raise concerns were that the provider might dismiss their concern at 66%, that the provider might not have the information, 43%, might have the time, 40%. And a number, roughly a third, were unsure that they would even be asking a valid question, or felt that they didn't even have enough knowledge in order to know what exactly to ask. There was support among women and providers to integrate environmental health into prenatal care. 77% of the women indicated that pregnancy-related healthcare is an appropriate context for receiving environmental health education. Roughly half of the providers felt that clinicians should be sharing such information directly with their patients, while indicating other avenues for education, such as public health promotion and other forms of education. Providers also see the need for upstream action. Roughly 8 out of 10 of the provider respondents felt that healthcare professionals should engage in advocacy for policies and regulations to reduce environmental health hazards. So that's a quick tour, very partial tour of the 2 surveys. And I now pass it to my colleague, Karen Phillips at the University of Ottawa Interdisciplinary School of Health Sciences, who is the PEHE co-lead, helping to carry this work forward, who's going to share some additional insights on our research learnings.
Thank you, Erica. You can go to the next slide. I'm going to present to you some data from the work of a couple of my graduate students that involve some complementary studies with practitioners and trainees. So the first study that we're going to look at is a small study looking at perinatal health providers and trainees across Canada. And so we were able to conduct a small survey, as well do some preliminary interviews with these groups to look at these providers and trainees' educational and clinical preparedness for addressing environmental hazards in pregnancy and engaging in environmental advocacy. Next slide. So their main findings, across the board, there was a widespread acknowledgement of the range and complexity of environmental hazards by both trainees and practitioners, although there was also a recognition in their formative training, the gaps in both instruction and practical training on environmental health risks. So trainees, as you see, 66% strongly agreed that there were gaps in their current program. Trained to take an environmental history, perhaps promisingly, slightly more trainees than perinatal health providers. Trained to take an environmental history in the context of pregnancy, pretty similar there. So again, still less than half, but a little promising. The more recent trainees seem to be getting at least some exposure, depending on, of course, program and province. In terms of looking a little bit more specifically, just as an example of one of the themes that we uncovered was a disconnect between theory and practice. So many of the clinical programs have practicum, internships, placements, and so this example quote from a midwifery trainee noting that there was a disconnect between the concepts of environmental justice, but the action in a clinical setting was not well explained or demonstrated. For practitioners alone, so these are active providers, we asked about explored barriers and practices in terms of environmental risk counseling and health promotion. Only about 42% regularly take environmental health histories with their pregnant patients. They noticed gaps in their knowledge of outdoor air pollution, including wildfires, exposures in the home, and water quality, and acknowledged their barriers to discussing environmental health issues with patients, where their own knowledge gaps, lack of institutional support, and again, as echoing Erica's comment about the patient's structural limitations, so inability or to actually take action. Next slide. So moving to a more recent study by second graduate student Danica Paquette-Rochette. This study focused more specifically on wildfire smoke exposures in Canada, a very topical environmental health issue. So once again, an English and French survey just recently concluded, also with a multidisciplinary group of health professionals. These are practicing professionals, and again, practice regions geographically concentrated Western Canada, with over 70% identifying that their practices were impacted annually or at least frequently by wildfires. Next slide. So our preliminary findings, a very small number, about 18%, strongly agreed that they had sufficient knowledge about wildfire-related pregnancy risks. So not surprisingly, only 21% felt they had sufficient confidence to provide guidance and resources to pregnant patients about wildfire smoke and pregnancy. 64% had no wildfire-specific perinatal training, and 54% felt that this was not accessible in their professional sector. So all of these findings are grouped across these different healthcare sectors. Gaps in terms of wildfires and perinatal health were identified as a lack of awareness and training, lack of clinical guidelines, and limited access to specific resources and tools. So I'll stop there.
Thanks so much, Karen. So now I will stop sharing screen so that we can see more of us on the screen. And we do have time for questions. So I will rely on Jack and Tim to support with providing questions if there are any that have been posted in the Q&A box or in the chat.
I don't see any questions right now. Tim, do you see any?
Not at the moment, no.
All right, so so we do have some resources available, and Tim probably mentioned it at the beginning, but there is a summary of the PEHE collaboration research available in English and French on the website. So I invite you to have a look at that and share that out. So we do encourage you to think of some questions to ask, but we will have actually more time for a panel, which will be
just lifted up his hand.
All right, thanks for doing this. Not really a question, I just have some comments. I remember going to a session that Erica, you spoke at about CPCHE back in, I think it was the 2014 session, and my takeaway was don't eat microwave popcorn. And I came home and it's kind of like, okay, all my patients don't eat microwave popcorn. You know, we threw it out. I said to my kids, no microwave popcorn. And it was really my first kind of exposure to thinking about, you know, environmental risks in terms of, you know, what we eat and you know, what's around us. And I think that the problem for, and I think it's reflected in your data. I think the problem for busy clinicians is they're busy, and there's 100 things that we have to talk about in a very short period of time, and this is one of them. And unfortunately, it gets lost. And I'll just give you a kind of a side answer. We're now preventing RSV infections in newborns. And there's two options. One is mom can get a vaccine, or the second option, which is thought to be a better option, is baby gets a monoclonal antibody. But it's so hard to have the conversation about, you know, here are the options in pregnancy, again, because we've got so little time. And so what we did was we created basically an information pamphlet with public health that we hand out at 30 weeks. So it's kind of like, here's this, read it. If you have questions, I'm going to see you back in 2 weeks. We'll answer your questions. And I think that's the kind of thing that we need to be doing. We need to be providing people with reliable resources. And we all know that the internet, unfortunately, is a reliable source of misinformation. So, people Google it and they're going to get all kinds of, information that may or may not be helpful. And so I think what we should be thinking about is creating resources online where we can direct patients to it to say, okay, this is really important. This is one really important thing in a bunch of whole really important things in pregnancy, but you can make a difference for yourself and certainly for your baby and your family. And this is where we recommend going. It's reliable data. We've put it together, whatever. So I think that part of this is creating the resources that people can get referred to, because again, we're all busy and it's hard to it's hard to get the time to speak to this in depth. And so having something that is at an appropriate lay language for people, simple things they can do. I would say that saying to people, okay, just eat organic food is not practical, right? We've got social inequity, rampant in this country and obviously other countries. And so, it's great for some, but it's not easy for others. The other thing is, as it relates to, the knowledge of the population and I'm an old clinician, and I would say it is very hard to change practice, once you've been doing it for a long period of time. We are not very good at knowledge translation. And so the best way to incorporate something into practice is by actually teaching it at the level of the medical students, the nursing students, the midwifery students, the residents in OB-GYN, residents in family medicine. Like that's the place to start. Because once they have it in their kind of background knowledge, then it's more likely to be incorporated into their clinical practice. Me going out and telling a bunch of older clinicians that you need to start to do that, they're going to throw up their hands and say, I never, had it. I never got trained in it. I don't have the background information in it. So if a patient asks me a question about it, like, I don't even know where to turn to. So I think the push has to be on, and not to say that you shouldn't try to change clinical practice, but the push has to be on really the education of the new healthcare providers, or the people who are going to be the next healthcare providers, to have it incorporated into their standard practice. And again, in the end, patients have to take ownership over their own health. We need to provide the information to them so that they can, make those decisions. Just some comments.
Graham, thank you, because you and your comments have outlined at least 2 and probably 3 threads that we are hoping to carry forward in this project. We have several months to develop strategies, and you referred to the need for authoritative and lay language educational materials. That is a theme of this work that we're trying to do together, so that we're not tripping over each other and not aware of other efforts. So for CPCHE, we're in the process of updating our top 5 tips and inviting the PEHE collaboration partner to help us in that endeavor, so that we're making the resources that providers would like to use and that meet the needs of people at a community level, which is also a key part of this project, to listen to people working and living at a local level, including prospective parents. So that's one thing. Educational materials, we're going to be diving further into that in an upcoming webinar. You've also talked about training, and you also referred to that need for basic environmental literacy. And we saw that reflected in the survey, that people are saying, I feel like I have a concern, but I don't feel like I know enough to be able to even formulate the question or to have the confidence to ask. So how can we be working in communities through health and social services agencies, through various ways that prospective and new parents are engaging in their communities to start to build that literacy? So, because the conversation can only happen if both the providers and the patients feel equipped and motivated and prepared to engage in those conversations. So that's the work ahead of us. So thank you for getting us started. I do want to, and we are going to move into an actual panel and we'll be probing a few of these questions. I do see a hand up from Sarah. If you can pose a brief question, because I do have some others that we'll get to, and then we'll pivot to our panel in a couple of minutes. So Sarah, the floor is yours.
Absolutely. Thank you so much for the presentation. My name is Sarah Rhodes, and I'm a project director at an organization called the Occupational Health Clinics for Ontario Workers. We're a clinic network in all of the major cities in Ontario that specifically have patients coming to our clinics with concerns about work-relatedness of their exposures and some of the health concerns that they're raising. Specifically, we've really been seeing a huge rise in patients coming forward with concerns about reproductive health, specifically in the plastics production industry in our particular case. However, so it's been really interesting, but also to see in the survey that you've just put out that I think it was about 91% of providers said that the workplace was a major concern. But yet we do see all these issues related to just the lack of reproductive health issues being seen even as something that could be work-related. And even in our workers' compensation system in Ontario, reproductive health issues are not even compensated at all in this province. So there's a lot of work to do. So I'm really just so glad to see this work coming out. And I think I have a similar question. We, for this work and related to the workers coming forward, we're producing a lot of new kind of questionnaires that we're giving to those particular workers to learn more about what's going on for them, but then also to produce educational materials in response. And that's something that we really do. I can share our website, but we have a lot of resources that we pulled together around heat stress and some of these other like wildfire exposure, that kind of thing in the workplace specifically. So I'm happy to share our information, but I also would really love if this network feels like a really wonderful place to be learning of, because we also need a lot of feedback on the materials that we're producing. So I hope that we can be in contact and share back and forth with the things we produce. So all that to say, thank you so much, and I'll pass off to the next person.
And please do share your resources and certainly your contact information, because we do need to. So thank you, Sarah.
Thank you.
A question from the, I believe it was John Malott. What formal training is provided to take a proper environmental exposure history? And I will invite one of our clinical professionals in the PEHE team to take that on. I suspect I know the answer, but. Jack or Mark, do you want to take that?
As far as I know, there is none. So there's no actual formal training. So that is definitely a lack. And similarly to what everybody else had mentioned, like for a healthcare provider to feel comfortable covering the topic, they need the time, they need the training, and they have to feel capable of answering questions and brainstorming. But there also has to be that advocacy level and the legislative level where we're creating spaces and healthy environments for people to make choices, and they're actually choices, right? So like it goes beyond that point of care, and it's impossible for one healthcare provider to do it all. So there is not really any training. There's a toolkit available for increasing information, but like there's no actual formal training. We're working towards that, obviously, and that's part of what we're doing here. But in nursing specifically, there is none, as far as I know, and in midwifery, there is none. So I'm not sure if somebody wants to speak from the physician perspective.
Mark, go ahead.
Yeah, I think in family medicine, there are some templates that can be used, but it's certainly not consistently a formal part of training. And so people come out with, I think there's two problems here that are related but separate. One is you can't treat what you haven't diagnosed. So if you don't do an exposure history, you don't know what the exposures are and what to do about it. And then the second thing is, if you develop a really nice system for doing an environmental history that's very thorough, you're going to find a lot of exposures that you as a physician don't know what to do about. And so the need is double. It's being able to figure out what the exposures are, and then it's people feeling enough confidence to be able to discuss with patients what they find out when they do the exposure history.
Yeah. And Graham, a very quick comment. We're going to then move into the panel.
Just at the medical school level, but it'll be at other levels as well. That the problem is, the curriculum is full. We tried to get a teaching topic related to women's cardiovascular health in, and the question that was pushed back to us, that this is at a national level, the Canadian Women's Heart Health Alliance, and the question that was pushed back to us was, what do we remove? Right? So you just can't add more without removing something. And I'm not saying that it shouldn't happen, but I'm just saying that's the issue that we're up against, is we've got a full curriculum and we're trying to add more into a full curriculum.
And in terms of what we heard in the survey, among those who were taking an environmental health history, many weren't really using a specific form, I think, but they did, a majority said, if there was a form from an authoritative source, we would absolutely use it. So that is certainly a gap that could be filled. And I think if a form is available, that can also be supported through continuing education and so forth. So we're now moving to our panel. And you have already had the good fortune of hearing some of our panelists speak already. So our panel includes Graham Smith, who was the co-PI for the PEHE Collaboration research, Jeff Masuda, who has longstanding involvement in the PEHE Collaboration as well as in CPCHE, Mark Sanborn, ditto, and also brings the important perspective of somebody working in rural settings, and Jack, whom you've met already with Kane. So welcome panel. And I do, for those of you who have posted questions, I've held a couple of your questions for our panel, but I am going to get them to kick off with a first question, and a reminder to our panel that we don't have a lot of time. So if we can keep very short comments in response to these, and then hopefully we'll be able to move into additional questions from participants. So first question is, what support do clinicians need to feel confident discussing environmental exposures with patients? And related, what part could professional associations play in building clinician capacity? And I do want to just note that we're focusing this panel in particular, there's lots of threads we could pull here, but we're focusing our panel in particular today on the opportunities for institutional leadership and action, including the role of health professional associations. So again, the question is, what do clinicians need to feel confident on these issues? And what's the potential role, what's the needed role from professional associations? So Graham, I think you've spoken a little bit to this, but I will give you the first word, and if you could just say one point, and then we'll pass it on to others, because I think others will want to weigh in as well.
Yeah, so just in terms of what societies can do. So I'm the editor in chief of the JOGC, the Canadian OB-GYN Journal, which is widely read by clinicians, health care providers. And one of the things that we've changed since I took over is we're now having special issues. We've got 3 coming out in the next 6 months. And so the potential is we could put a special issue together on this topic. Ideally, it's not just reviews, that there could be there could be something written about here's how to take an environmental history. But original research, is always the best, because that's what benefits our impact factor. But just thinking about it as I'm listening and we're talking, that certainly is a possibility, with enough kind of runway ahead of us that we could start to think about that, and people could get involved and submit manuscripts to it.
Excellent. So I'm going to move to Marg with another physician perspective, and then we'll jump over to Jack, who brings both nursing and midwifery into our conversation. So Marg, quick thoughts on our first question.
Yeah, so a couple of things stand out from the what you presented in the research findings, and one of them is that 77% of patients want to get this information from a healthcare provider, but only 23% of them do. So they're trying to rely on the internet or media or other things that are not as reliable. And the second thing is that the healthcare providers know that this is very important, but they don't feel that they have the knowledge and the resources to deal with these things when they come up. So those are, I think, two really important gaps that we need to look at. And I think one thing that the research does is it gives us some ammunition to go to our professional organization and say, this is what patients think and this is what providers are dealing with, and is there something that you can contribute to closing those two gaps. And I do think that we need an environmental exposures checklist or form that is time-saving for physicians and other healthcare providers, that's evidence-based. And we need something which is very important that we can integrate with electronic medical records that are in common use. So we used to do this by handing out a questionnaire in the waiting room and getting people to fill it out, and then we'd look at it when we had our visit. But you really need that information to be part of the electronic medical record. And I don't think we've really gotten our heads around the best ways to do that and how to do it in an office setting.
Excellent. And I might add that because the PEHE collaboration exists and because it includes many, if not most, of the clinical professional associations in Canada, physicians, nurses, midwives, etc. This is an opportunity to perhaps think laterally and think together across disciplines of what would those items be? How can we ensure that they're incorporated into routine practice via the types of forms and electronic records that you've mentioned? So that's another, I'm just taking note of another challenge that we should lay down for ourselves to try to see if we can move that in addition. Jack, do you have thoughts you'd like to share on this?
So many thoughts. I think right now we also have to look, when it looks at institution, be able to actually put this in, we actually have to look at the healthcare system and think about, like, I don't know if you remember when the Alma Ata came out and it was the primary healthcare, health for all, the right provider at the right time. So I think with this topic is so important, but we have to be strategic. Who's the right person at the right time to cover this information? And when does it go further, if that makes any sense? So like, if we're looking at the network and how we connect with pregnant people and people who transition to parenthood, when is the best time and moment? And how can we as institution organizations ensure that those barriers that are sometimes, most often structural, that prevent them from creating change? Because people, when we're looking at it from an equity perspective, when I'm doing home visits with a pregnant person, there's a very big difference doing a home visit when the person is 3 hours away from where they're going to be giving birth. They have other children and they have no transportation and end up catching the baby at home. There's a very big difference between that parent and a parent who is maybe a nurse or a healthcare professional as well, when it comes to accessing information. So for me, it's like not only that questionnaire, because if people aren't able to actually put in place what they need to because of structural barriers, it's up to people like Jeff, Graham, Erica, myself, with the collaboratives and those institutions to move for that advocacy. And it has to look intersectoral, right? So how can we include this in places where people are interacting, right? So there's like family center coordinators, for example, there's like healthy baby sits, there's paraprofessionals, where there's like so many other options that actually make it so that it incites the conversation. So it's like thinking a little bit outside the box and coming back to that primary healthcare and thinking equity, diversity, and inclusion. Because if we're looking at getting the biggest bang for our buck, we have to look at who is most affected. How can interventions make the most difference for people who are most at risk? And that's where it's the institution. We need to raise awareness, and we also need to have it raise the importance, right? So that's where it's like as Graham mentioned, that it has to be in the undergraduate level in the pre-licensure programs. But that's where that intersectoral collaboration, the working smarter, not harder, right person at the right time. And instead of dreaming big and trying to include stuff, include those really important elements that make the biggest difference. And these elements will be different depending on where a person lives and where they live, work, and play, essentially.
Okay, thank you. And your comments, which focus on the need for an equity lens on all of this work, is a really nice segue to my next question. for which I'm going to invite Jeff to kick us off, which is how can we best work together through research, knowledge mobilization, and advocacy to expand beyond behavioral health promotion, which is individual based, to center population health perspectives, including the health protection.
Thanks, Erica. Well, I will maybe just start by expressing my gratitude to Jack for covering a lot of what I was hoping to say. So given that we have limited time, it allows me to focus on maybe a little bit more in depth on some related matters. Yeah, I guess I would just start by expressing gratitude for the existence of PEHE. PEHE has, as Erica said, been around for 10 years now. No signs of that changing, at least as far as I know. And so when it comes to creating a space where we can have these interprofessional, intersectoral, and conversations that transcend the provider and the patient kind of divide, PEHE is very unique in Canada in terms of like advancing the opportunity to think through the complex challenges that are in front of us when it comes to not only education, but advocacy, as others have so adequately already expressed. There is an important piece for advocacy here. Graham, I really appreciate your willingness to create special issues. I'm a big fan of special issues, and in addition to impact factors and primary research, they also afford opportunities for invited commentaries, editorial commentaries, where we can really push that advocacy piece in targeted ways to audiences. So 2 thumbs up for PEHE writing an invited commentary at the front end of the next special issue. Yeah, I mean, PEHE is called a collaboration, but it really is also the opportunity to be a movement, and not a novel movement. The environmental justice movement has been with us for quite a number of decades. And we are more than just the hats that we wear in clinical spaces or academic spaces like myself. We're also citizens. We're also parents, siblings, children, uncles and aunts. We also face challenges, whatever our socioeconomic position, whether we're at the grocery store choosing which cleaner we are willing to pay for, or which neighborhood we choose to live in. Not everybody is in the same place, though, like living in the same context. So that one part of the national survey that was really striking is that half of the respondents cited cost, and cost, of course, is another word for control. And I think Jack's really expressed that well, but it's not just about consumer decisions. It's not just about whether we can afford particular products, but it's control over precarious living conditions, control over whether one can afford to do anything when they find out that they live in a contaminated community, control over the workplace when you're a non-unionized worker, a temporary or a gig worker, and things like that. So we all need to be working together as citizens to, as Erica so aptly put, move upstream, and not only move upstream, but recognize that we're all in the same damn stream, whether we're, a nurse or a custodian or an Uber driver or whatnot. Like, we're all in this together. And when it comes to climate change in particular, wildfire risks that we now see every single summer from coast to coast, this is affecting us all. And so we need to be working together. I guess I'll just maybe close with one last deep concern about issues of equity, is that our ability to even ask these kinds of questions, let alone address the complex changes that need to happen, is really under siege right now. We're seeing things happening south of the border with the attack on DEI. That's not just happening south of the border. That's happening right now, right here this week in Canada, where research like PEHE is being put under a spotlight and coming under attack by interest groups that would see any kind of equity focus in research villainized. So we all need to be thinking about how our affiliations to PEHE, our roles as the power that we have as academics and clinicians and practitioners, to really advocate for ourselves, advocate for the work that we do to protect this important work so that it's not undermined in the decade to come.
Excellent. Thank you so much, Jeff. And I'm wearing my CPCHE advocacy hat. I want to build on what you are all saying, particularly Jeff and Jack, about that advocacy piece. Clinicians, healthcare professionals are among the most trusted people in our society. Voices, these are voices that are well received and effective. And as we look at things like chemicals management, the response to climate change, some of the other threats that people have just mentioned, how can we be using our collective voice to be part of those consultation in that direction towards our governments as they lead us through a very fractious time in Canada and in the world. So I welcome us to take on the charge to be voices for how things should be as we navigate difficult waters. We do have a few minutes, and I'm going to turn to some of the questions that have been shared with us from participants. So we have a question here from Dr. Bethany Ricker. What do we have the evidence on what environmental exposures are harmful, to what extent, and how to mitigate these harms? Do we have the information to translate into educating practitioners and patients? There are, of course, many exposures. So this is a broad set of knowledge. Do we know what types of evidence we have and where there are gaps? So panelists, if anyone would like to take that on, please do. Graham, you were first off the hop, so the floor is
You know, one of the most important international studies ever done was MIREC, maternal infant research in environmental contaminants. This was a study done back, it was run by Bill Fraser and Health Canada, Ty Arbuckle, back in the early 2000s. Kingston, I was involved with it because Kingston was a recruiting site, and it's still producing publications. You know, they're looking now at you know, linking exposures in pregnancy to these kids are now, you know, going through beyond puberty. So there's kind of the longer term health follow-up studies as well. So lots and lots of publications from MIREC. And again, thinking about, you know, having a special issue, I would invite MIREC to be part of that. The problem is, and I think going back to Marg's question or Marg's comment earlier, is, you know, people are going to come and say, I want to get my lead level done. But I think, you know, the most important thing is, you know, we need to be talking about prevention. It's not treatment, because we're not going to be giving treatment during pregnancy for lead levels or copper levels or, you know, what other environmental contaminants. So I think that the most important thing here is prevention or reduction in exposures. But yeah, I think there's lots of data out there about the potential harms of environmental contaminants. Much of it is Canadian data.
Mm-hmm. Excellent. And we'll note in the chat the link to the MIREC study, which is ongoing, is there. So please invite you to check that out. There is actually a connection to the PEHE collaboration, which we'll share in a future reference, a webinar. I do want to build on what you've said to point out that some professional associations, for example, ACOG in the US, American College of Obstetrics and Gynecology, has done the work of issuing a statement about, of all the hundreds, literally, chemicals, here's some priority ones that they're encouraging all providers to engage on. So that's some of the work that we can explore through this work. What would be the short list? And the other thing I would add is that in CPCHE and the work that Jack and many others do, there are simple practices that anyone can do that reduce exposures in general to toxins. So as an example, bust that dust. So when we buy products and they have, you know, plasticizers in them and fragrance chemicals and all manners of things, lead and other things, that all settles into the dust. It's the little kids who are on the ground who get most exposed, but all of us get exposed through house dust, which is re-entrained into the air. So if we just get the wet cloths out and do more frequent dust busting, that's a way of addressing multiple contaminants in one go. So those are some of the supportive actions to provide to families, and it's effort, but it's zero cost. So we are not able to take on additional questions at this point. I will note that there was one here. What are the most critical preventive actions that pregnant women can and should take? That is something that I think is a live question here, and one that we are working on. we collectively and many others as well. And that is something we can dig in further on in one of the upcoming webinars. And of course,
for sure.
yeah, so it is almost at the top of the hour, and I do want to very much thank our panelists and thank all of the folks who have weighed in with questions. You know, clearly we could have a much longer discussion, but I am excited that we've had some ideas shared by participants, by panelists, and these are threads that we are actively collecting and will continue to weave as we move forward and try to get us well situated in Canada with all these multiple collaborating sectors to move forward and do the work that needs to be done. So looking ahead as we draw to a close, a couple of upcoming events. So as I mentioned, there's 3 webinars in this series. The next one is going to be in January, date yet to be determined. And it's focusing on that community level work, that equity focused work that is, you know, exploring ways that people have experience with or ideas about where we should try to move in terms of building community literacy capacity and advocacy around environmental chemicals, and including a rights-based lens, environmental justice, the right to a healthy environment, et cetera. The third and final webinar, at least in this series, would be addressing the informational materials. And that's an area where many organizations are doing important work, and we need to be connected with one another so that we can make sure that the scarce resources we have in this sector in Canada are applied most effectively, and that we're building the resources that people want and can use. So please stay connected on the project page there. On the CPCHE website, you can sign up for project news. That is how we're going to share information about upcoming webinars and opportunities to get involved. So please do that. Sign up for that MailChimp newsletter, and please be in touch. I've put my email here and my colleague Tim's as a starting point. We are, of course, happy to connect you with our panelists or any of the many organizations and people that we have the good fortune to work with in this collaborative effort. And then finally, if I can advance the slide, just a real sincere thank you to all of you for your interest, for your energy, and for helping us to build the knowledge and momentum to move this work forward. And many thanks to those who have contributed. So with that, I will draw our meeting, our webinar to a close. And on behalf of all of us, the PEHE Collaboration, CPCHE, CANE, our supporting collaborator from Health Canada, I thank you for your attention, and we look forward to doing good work together in the future. So thanks so much.